Hey guys, this is Dr. Munson. I have been appointed to lead the meeting today in lieu of Dr. Burchett as he is out of town. So I'm going to give everybody just another minute or so to get on. I see already that we already have a quorum. Dr. Sawyer, I'm so excited to see your face. A lot of times you just call in, so that's exciting. And then I assume Dr. Compton, Dr. Upchurch, you guys are doing okay?
Doing good.
Yes.
Good deal.
The waiting room is cleared.
All right, so we're going to go ahead and get started right on time. So we definitely already have our quorum. So our first thing that we've got going on is just to approve our minutes from our last meeting. So I will entertain a motion and a second.
Madam
Make a
Chairman.
motion.
Okay, I'll second.
All right, so moved. And do I have approval from everyone? I am an aye. Anyone else?
Yes.
All right,
Yes.
so great job. So we're going to move along to our old business, which is item 4. So first one is to DMS. Do we have any representative from DMS on the call that can comment on the no-show report to share with us for optometrists?
This is Erin with Medicaid. I wanted to apologize first off. It looks like Justin sent me some reports after your last meeting, and I've searched my records and I do not see where I have sent those to you. So I have them in an email prepped, ready to go. So I do apologize. I don't know if Justin's joined yet. I believe there might be an update on the dashboard they've been working on, but I don't want to speak on his behalf. Is there anybody from policy that could speak about that? Okay, I don't see him yet. He could be hopping off one meeting onto another. So I do apologize for not sending that out. That is completely my fault.
So you'll go ahead and get that distributed to our TAC members?
Yes, ma'am.
Okay, excellent. And then I do recall before that there were some discrepancies between what offices were seeing with their personal tracking of no-shows and then what was on that report. Dr. Compton, I believe that was your office. Am I remembering that correctly?
I was at least one of them.
Okay.
I don't have anything today to compare to what we would have gotten anyway, but I'm anxious to see it.
Yeah, so
it's a problem.
Yeah, and that's part of why we were wanting to see these numbers. So I don't know if you can speak to anything about the discrepancy, not you, Dr. Compton, but DMS, if there's anybody that can speak to the discrepancy, or hopefully in this report that you're going to email out, then maybe that would be something that has been cleaned up a little bit.
I cannot speak on that. However, I'm happy to, once you guys look at it, any questions you have, please send those to me and I'm happy to get those looked into, because I know the goal is they want to try to make this as accurate as possible. And so any questions you have or any discrepancies you see, feel free to email those to me and I can get them over to Justin and his area to look at those. And again, I'm so sorry I hadn't sent those out. I try to get those things out within 48 hours of receiving them. I'm not sure what I was doing that day.
That's
okay.
Okay.
And Justin's joining right now, so he might have an update on the dashboard.
Okay. So I'm going to go on to the next one real quick, because this should be an easy one. Do we have any update on the kind of electronically linking the Kentucky Board of Optometric Examiners to electronically send the license over to DMS?
This is Jennifer Dudinsky with Program Integrity. I wish I had better news for you, but we had continued to try to reach out. Our IT team and my enrollment team has continually tried to reach out to the contact that we had. We were not getting responses. And then just recently, our most recent reach out to them, to our contact, we got a kickback on the email stating that that person was no longer employed there. So we do not have a contact at this point. So we would be grateful if you all had a contact or could provide us with a contact. We're happy to continue reaching out, but at this point, we're just not getting anywhere.
So there is a new executive director. Her name is Christy LeMay. And so that would be your target. And it's a state email, but it's just Christy with an I .lemay@ky.gov. And I would put it in the chat box if I was savvy enough to do that, but I'm not.
Honestly,
So-
Jennifer, somebody dropped it in the chat. I will send it over.
Thank you. Thank you for people
Thanks.
savvier than me.
We will reach out and try that.
So I would hope that interaction is going to be more fruitful, but that will be something that we'll keep on this agenda. But I wear many hats, and so I also am a newly appointed to the KBOE. So I will try to help on both fronts to help that be something to benefit all of our Medicaid doctors, because I think it just would be easier from every side possible. So if you want to start with Christy, I think she will be a great help to you to get this ball rolling finally.
Great. Thanks so much, Caroline. I appreciate it.
You are welcome. So next is kind of continuing our discussion on the 2023 new Medicaid vision material benefits for adults and children. First, CMS have they approved the new enhanced benefits? I feel like I know the answer to this, but I just want to double check.
Hi, this is Justin Derringer, Acting Director for the Division of Healthcare Policy. Yes, CMS has approved all of the changes for the vision expansion.
Okay. And have there been any changes made on the new regulations based off the recommendations that we had made?
So we are still reviewing those recommendations, and that you all will be receiving a statement of consideration for your.
Hey, Justin.
Yeah. Oh, yeah. Go ahead. There you go, Jonathan.
Sorry. So the E-reg was amended. And so we did change we changed daily to disposable. We did not change the medically necessary clinical criteria, because you are already subject to 907 KAR 3130. So that there is already an understanding that services have to be medically necessary. And so we are going by that overarching regulation and overarching concept for medical necessity. And then deluxe frames, we did change that to the manufacturer warranty, and instead of an expectation that you have that. That's just for the E-reg. We will be filing the O-reg SOC by the 15th of this month. So the E version of the reg will be on this week, I guess next week. So it'll be on Tuesday's R's committee. And then the O-reg will be on next month's.
And Jonathan, they'll get a copy of that statement of consideration. Is that correct?
The E-reg was already sent out. So you all should have it. The people that requested it, so I believe your lobbyist requested it. So I sent it to her.
Okay. So aside from that, how would we receive communication of these changes? Would that be something that's our onus to watch for, or is that something that the department would be letting us know without having to ask in our quarterly meetings?
No, we're so this is done by the CHFS OLRA. So it's a overarching cabinet thing, and we do not send SOCs or AACs to groups that don't ask. It's just it would be too much of a administrative burden on us to do that. So you have to ask if we send it. So you can ask for it in this meeting, but you can also ask me to send it to you directly.
And then
Okay.
there is a if you all are not signed up with RegWatch, I would strongly encourage anyone that's interested in any changes to administrative regulations to get on you can get on the cabinet's website, or you can get on the Legislative Research Commission's website, LRC's, and you can sign up for RegWatch is what it's called. And you can tell them exactly what area you're interested in or what specific regulations you're interested in.
But
Go ahead, Jonathan.
if I could interrupt, if you sign up for RegWatch, I send you all the regs. I'm not gonna. There's a chance to kind of factor into a few different topics, but I send everything to everybody because we don't want to guess that you may not be interested in a certain type of reg. So everybody gets everything, and I don't send out the SOCs or the AACs to that list. So you'll just have to reach out to me with when you expect them.
Yeah, we are already.
Or say in your letter that you want us to send you a copy of it.
Okay. And then can we clarify who is eligible for adult glasses, which specifically is if or when a QMB would cover the glasses, which I know that's kind of a separate little subset. So does anybody have an answer on that one?
Yeah, so some of the language that was entered on the, I think some of the language that was on the actual fee schedule is not quite correct. So Medicare, Medicaid dual eligible members, services were added to the Medicare bypass list. And so those should be on there, and that'll be effective, or that was effective back to January 1st, 2023. So and so what it should state is that Medicaid will pay for QMB members, and claims have to be submitted on crossover claims and not a straight claim. And it will not pay when a member is SLMB or buy-in. So all that's going to be on the fee schedule. If it's not updated today, it will be within the next week or so.
So those dual eligibles, it has to be filed with Medicare first. It will get denied, and then it will come through as a crossover, and then QMB would cover the glasses on the adult benefit.
That's correct. And it was added to our bypass list. So we'll pick that up.
Okay. And then are all lens types listed in the vision fee schedule considered medically necessary? Meaning like the example of like progressive lenses, is that at our option if it is on the fee schedule?
Yes.
Okay.
So
Okay,
everything's, everything for Medicaid, as you know, is medically necessary. So.
Okay. Okay. And then flipping over from DMS to the MCOs, the question would be, how are the MCOs reimbursing for adult contact lenses right now, if only medically necessary? So we can go in alphabetical order. So I'll let Avisis go first.
Hi, good afternoon. This is Kim Gray, strategic client partner with Avisis. So we are currently covering contact lens for medical necessity only.
So that for adults, is it different than children?
No, it's not.
Okay. And so you have, and this is something that I've come up with in my own office. Avisis has come up with their own subset of what is medically necessary, different than what has previously been released by the state? Or are you going just straight by what the state's medical necessary language is?
Is there anyone else from Avisis that could potentially answer that question that's on the call today?
Yes, sorry, I'm trying to get myself off mute. This is Danny, I'm the product specialist. So we are following the CART, we are following what the state considers, and then we also have some additional that we feel is medically necessary as well.
So what the state has in their language, and additional then that you would cover above and beyond.
Yes.
Okay. And then
is medically necessary. So you'll just have to send in the charts for prior authorization. And then if there's anything that's additional, then we would take that on a case-by-case basis through the UM department.
I'm going to keep Avisis on just so I don't have to go back and forth between you guys. So then the next question would be, are you paying for more than one fitting or evaluation if it's medically necessary?
Yes.
Yes, that would go through a prior authorization process, and we would cover additional contact lens fittings and evaluations when medically necessary.
Okay. And then if the patient goes through the medically necessary contact lens fit, doctor bills for that fit, but ultimately the patient is unable to wear the contacts for a myriad of reasons. Does that wipe away their glasses benefit, or are they still able to get the glasses benefit?
Danny, I believe we would review those on a case-by-case basis and would require prior authorization to approve the glasses at that point.
So
Is
if
that
sort of, so what we would do
Thank
is the glasses would be then paid through the dispense and the materials. And if the contact lens fitting comes in and they do not receive contact lens materials, then the contact lens fitting will have to either be appealed if there's already a claim on file or prior auth to determine what the reasoning was. And if it is appropriate, we will pay that fitting.
So what if the fitting was already paid? Because you're gonna, it's a process. So you're gonna file the claim and then you have a process, and then ultimately they don't end up getting the contacts. They're not able to tolerate them. We'll use that as an easy example. Because the coding for a contact lens fitting fee is a service, whereas the coding for the physical, tangible contact lenses is a material, just as the glasses are. So does that contact lens 92310, does that fitting code automatically kick out someone from being eligible for the glasses benefit, or is it the tangible V code that is for the contact lenses that kicks them out from being eligible for glasses? Is that
so? Either the fitting or the material for the contact lens will cause the ineligibility for glasses.
okay?
But the provider can pay. So it all depends on when that claim comes in, what comes in first, if it's paid, not paid. It depends on the scenario.
Okay.
But ultimately, if both do get paid and that member is not able to utilize that contact lens, then the glasses would supersede the benefit.
Okay.
And they would receive the glasses. So because it's a one or the other, whichever gets paid first exhausts the benefit, and then it takes away from the other piece of it.
Okay. What if a patient wanted both and met the medical necessity criteria, and they wanted Avisus to pay for the fitting? They were going to pay for the lenses out of pocket, and then they wanted Avisus to pay for the glasses.
That would have to be looked at on a prior.
Like they're like a -10 person. So they obviously cannot go without glasses, but they also are going to function better in the world in contacts.
Right. Or keratoconus or something. Right. So that would have to be looked at on a case-by-case basis. And we're not anticipating that it's too often, but they can reach out to our UM department and they can take a look. And then our clinicians will, the peer-to-peer will review.
And that's something that we should still expect to get a turnaround and answer for that within 48 hours.
Oh, yes. Yeah. Anything that comes in through the UM department on a prior auth piece, yes, we would follow that turnaround time. I do not know exactly about the appeals process and turnaround time because I'm not in that department, but we can get back to you on that and let you know.
I'm just playing kind of devil's advocate because I wouldn't want somebody in the situation that I gave that would have a delay of care trying to figure out one versus the other. So, but I understand the need for a prior authorization on it, but I would like it to be that tight 48-hour turnaround and not have to, because the appeals process, much love, it's a lot longer than 48 hours.
Right. I want to say that usually it doesn't get to the appeals process until it is not handled by the PR department. I want to say that most of the providers do reach out to our PR staff, and then PR staff will reach out to our UM or Dr. Worth. So it sort of gets escalated before it gets to that department necessarily. So I do believe that we do have a very tight turnaround time due to the urgency of the situation.
Okay. All right. That's great. Okay. So I think that's all of those for Avisus. So we'll go on to iQuest.
Dr. Munson.
Sorry.
Question. If I heard right, the medically necessary contact lenses follow CMS's guidelines, but Avisus has added some other criteria. How do we know what that is?
We have our clinical protocols on the provider portal, so they can pull up the medically necessary contact lens protocol specifically.
So with this situation, some MCOs will cover one thing and some will cover another, more than likely. It's a little tough to keep up with when there's.
It's
different criteria
Yeah,
for,
I can't speak for the other MCOs, but I know that we are covering at minimum what the state covers with additional,
Okay.
if necessary, after
All right.
review.
so I'll look that up.
Then any other TAC members have any other questions on this for Avisus? All right, hearing none, we'll move on to iQuest.
Dean, you want me to take this? She's probably on mute.
I am. Thank you, Dr. Davis. And sorry, I couldn't get off mute quick enough. Yes, please.
So I'm John Davis. I'm with iQuest. Let's start with the questions on the agenda. Right now, we're reimbursing for adult contact lenses when medically indicated. They rewrote in the current chapter 632. They rewrote the criteria for that. It's pretty simple. It's basically if the doctor thinks they need them, and there's a medical indication in their minds, then they get these contact lenses. The state removed those other criteria that they used to have of the ±8 and the 4 diopters of an-ISO. Not sure why they took that out, but they just eliminated that, as you guys probably are aware.
Mhm.
So mostly it's going to be rare instances when there's a true medical indication, because basically the criteria says it's a medical indication prevents the use of eyeglasses. So again, it's a little bit judgment there on your parts, I guess, right? But we're going to be covering them with PA, no problem. I wanted to also say we will recognize more than one contact lens fitting in whatever period as necessary. That would include the 92310, the 13, and the 92072 as well. Bandage contact lenses, those are unlimited. They're not even part of our prior authorization process. And I think that's 92071, right? Bandage contacts, guys?
Yeah, and that wouldn't be applicable here, so.
Not at all, no, right. So we don't have PA requirements for that. That's just a standard procedure that you do at will. So yeah, multiple fittings were indicated. Sometimes that happens. Maybe it's post-surgery, maybe they have surgery along the way, maybe they have corneal cross-linking done and a keratoconic, and then 3 months later they need to get their lenses redone, things like that, right? What was the next question you wanted me? Let's see here.
If they're going to be fit with the medically necessary contact lenses and then they're not able to wear them.
Oh, right. No, we
are they
don't,
able to get glasses?
Yes, that's a definite. Yeah, we feel like if patients need medically necessary contact lenses, they certainly need glasses to go along with that as medically indicated. So that would apply. So we don't have that restriction, no, for Anthem members.
So that would mean that if they had billed and been paid for that 92310, the contact lens fit, then material purchase or a claim submitted for the materials on contacts, that they would automatically be able to get the glasses without having to go through prior authorization or anything.
That's correct. It's not a preclusion to the glasses. And we would make an assumption that if the materials, in that scenario you just mentioned, if the materials were billed and we paid you for them, that you would the doctor would do a corrected claim and reverse the contact lens material part anyway. So that would, because you didn't dispense them, let's say as an example. If they were ordered and they were billed already, then the patient, well, they may not have picked them up, whatever, right? There's a lot of reasons. We would expect you guys to do a corrected claim and then reverse the materials, but that's still not going to get in the way of the glasses benefit. Okay. Something we just assume that you will do, but the professional fees are not reversed. The services have been provided. That's not fair. When you provide a service, you can't reverse that because for whatever reason. Let's see. I think that's it, right? On those.
Yep, that's subject? Everything. Yep.
Okay.
Do any of our TAC members have any questions for iQuest?
I actually do have one question, if I could, since we're on it. I think you covered it, but I didn't really understand it. So patients who are eligible for contact lenses, right, medically indicated, daily disposables potentially would be covered as part of the contact lens that's determined they need, potentially, right? A year's supply. Did I understand that correctly?
So that's a CMS question. That's not a me
Well,
question.
Oh, okay.
that's correct.
Or
Oh, I'm sorry.
DMS, excuse me.
Yeah, Jeremy, what's your feeling about that? There's no difference, or
No,
Is that Justin? Can you
yeah,
speak to that?
this
Oh,
is Justin. Yeah.
Justin, I'm sorry,
yeah,
not Jeremy.
that's okay.
Apologize.
No, that's absolutely correct. So, as a matter of fact, I have, today, I will send you all, when we get off of this meeting, our proposal for, reimbursement amounts to be added to the fee schedule for contact lenses. So I think we have daily, weekly, monthly, and different types of contact lenses and the amounts that we will reimburse for each one of those based on the code. And so we'll be sending that to you all to kind of look at and review, give us some thoughts on. Those are not set in stone. Those are just our, we wanted to give you all a chance to look at them first before we added those codes. But yeah, it's a yearly supply and
Of whatever kind the doctor wants to fit.
that's exactly
Okay.
right. Whatever the kind of doctor prescribes. That's
Okay,
correct.
good. Thank you.
Yep.
Okay. Well, hearing no more questions for iQuest, thank you so much. And then we'll move on to March and see if there's somebody on the call that can go through these questions for me.
Hi, good afternoon. This is Leanne Ellis. I'm the provider relations advocate with March Vision.
Hi
Dr.
there.
Munson, I'll
So
go ahead. Hi, I'll try to answer all of those questions at once. And if I leave one out, we can go back through that. We
Okay.
cover contact lenses, the medically contact lenses as medically necessary per the guidelines set forward by the state. We will pay for another fit as an exception, and that would need an authorization. Going to
Okay.
the question if a member is eligible for medically necessary contact lenses and glasses, we would only pay for one or the other, but that would be looked at a case-by-case basis with an authorization.
So I guess that question is a little more specific than that. So it is a doctor that would bill for the fitting fee, the 92310, on the fitting of the contact lenses. But then the patient was not successfully able to wear them, didn't want to wear them, 1,000 other reasons that they didn't go through with the actual need for the tangible lenses. So that the tangible lenses would not be billed for, only the fitting fee. The question is then, could they flip over and get their glasses benefit because they didn't use the contact lens benefit, the actual
Sure.
revenue multi-packs or lens?
Sure, I understand. That would be considered a one-off and can be a benefit exception.
Does that require a PA, or is that something that's just going to go through like iQuest just goes through, or does it need a PA like Avisus?
It would need an authorization so the benefit exception could be made and the member can get their eyewear.
Okay. Okay. Do any of our TAC members have any question for March? Okay. Seeing none, then I appreciate you all for giving that clarification for each of the individual MCOs. And then we'll go ahead and we'll move on to new business. And so the question had been posed to ask the vision fee schedule changes and revisions. They are posted on the DMS website. There have been several. And so the question is, how do we track what has been changed, added, deleted throughout the year? Are there notifications that DMS will send out? What do you got for me, Justin?
So, this is kind of a new or a newer thing with the expansion services. Most of the time when we do fee schedules, we do them in January and we don't touch them again until we put them out again for the next January. We're constantly working on them and researching them all year, but those don't usually change but once a year. Every once in a while we will add or change a code, but it will be very specific, usually based on a provider group or sets request. And after we do all the research, we'll change maybe a price or add a code or remove a code. So having this brand new dental, vision, and hearing expansion and services, is something that we weren't used to doing, having so many changes to the fee schedule. We're constantly trying to upgrade and accommodate you all, the providers, the MCOs, to make sure that everybody's getting exactly what they need, and we've got the best care possible for our recipients. So in order for us to do that, starting July 1st, all of our fee schedules have a tab, and that tab has all the updates that were made from when we first put it out on January 1st. So you can click on that tab and look at all the updates and what dates they were made, and they're highlighted, and so you can see everything that's been changed. There probably are going to be there are some fee schedules on there now that don't have that tab because they haven't been changed since July 1st. But moving forward and starting in 2024, all fee schedules will have that update tab that you can click on. You can sort it by date they were changed and what was changed, so that you can always be up to date on exactly what's the latest changes were to that fee schedule. We don't currently send out any provider information or anything like that usually, although we do have a few provider letters that are going to go out about some prior authorizations that we removed and some other things. We usually just adding or changing something on a fee schedule we don't typically send out. Now with the contact lenses, we will send something out when we add the pricing for those. If it's a big change, we tend to do that. But with the vision, hearing, and fee schedules, there've been so many changes that the easiest way right now to kind of look at those is that tab. I hope that answers your question.
It does. This has been, I mean, I've been in practice for a long time and I'm used to just the once a year fee schedule change. So this has been like drinking from a fire hose. So is there any potential that because of all these changes that maybe the department would consider a kind of communication to, I mean, you've got a way to contact every provider type to say, this has changed, or to say, this is how you find the change. We're not going to tell you every time, but this is where you go to see it. Because many of the Medicaid providers would have no clue that this is changing, and at least to give them that information, the onus is on them, but you have provided them with the where to find out this information.
Yeah, I think that's something we're constantly thinking about, trying to come up with different ways to keep everybody informed. At this time, we feel like that on the fee schedule, on that update tab, is probably the easiest place because we've made changes to it, as you all know, and then we've went back and made changes to those changes, or we've rechanged it. And, we would be constantly sending out provider information on, all right, we changed this, now we removed it, and then we added it, and then we changed that, now the fee's this, and now it's that. And so in order to not have that, kind of craziness, we try to keep it all on that tab, that revision tab, so that you can see what the latest is and where it's at. We're still open to looking at ways on making our website more interactive. I know we talked about no-shows earlier, and I was hoping that would be done back in January or February. And they tell me it's just within another month or two. But you'll be able to get on there and click on that no-show dashboard online and see, how many no-shows are in your area for what provider type, what the reasonings are that they're having no-shows. All that information will kind of be at your fingertips. And so we're hoping that we can, as we create some of these dashboards and some of this interactive usability by our providers, that we can start, maybe even adding these type changes in there, where you can click on your, fee schedule type, and it brings up the last 5 or 10 changes, something like that. We've had discussions like that, but it's all kind of rolled into our IT and trying to create some more systems that help everybody keep more up to date without being bombarded, by this change and that change, and maybe not getting the latest thing, maybe getting this letter, but missing another letter that updates the letter before. And so you have everything that's the most up to date we have right there on the fee schedule at this time. And hopefully in the future, though, we can have something a little better.
Okay. So can you explain how the tab works? Because when you go online, it's not apparent where that tab is. So we can't even see it online to be able to look at the changes you're talking about.
So when I send the pricing or the proposed pricing for the contact lenses, I'll send a little kind of a demo or instruction sheet on where to find those tabs and how to look at that.
Okay, that would
Will
be
that work?
great. That would be
Okay.
very helpful. Yeah,
Okay.
thank you. Okay, so I'm going to ask the same question of the MCOs also. So we'll just go in alphabetical order. So for Avisis, with, you know, in light of all these changes that are happening, how do we see that those changes for Avisis? And then also, how are our member doctors notified that changes have happened from Avisis's fee schedule?
My
So anyone
apologies.
from-
My
Thank you.
apologies. I was not getting off mute here. This is Kim Gray with Avisis. We do make the updates and update our vision plan sheet, and then we post that to our portal. And then we also have the availability of our provider relations staff to communicate that to the providers.
So how exactly would that be communicated? Is that a phone call, an email, a letter?
Well, I know we posted to the portal. To be honest, I'm not sure how. Is there anyone from provider relations that could jump on and answer that question? Miranda? My apologies. I might have to connect with one of my colleagues to just clarify how that is sent out from provider relations.
Okay. Because again, same thing for DMS with these, this is like drinking from a fire hose. There's changes all the time. And so knowledge is power, and we would like all of our providers to be able to know when those changes are made. So any communication would be great, because it is an insurmountable ask to go to all these websites every day to just track and check and see if something has changed. I have patients to see. So that would be great if you can come up with a way that these could be more effectively communicated.
Yeah, absolutely.
So let us know.
Yep, I should be able to circle back with you here in a second. I just want to confirm. Thank you.
So we'll move on to iQuest. So can you explain how that process works and how the information is disseminated to your member doctors?
Right. So when we identify something we need to change, whether it's a frequency of a new benefit, or a benefit that's terminated or discontinued by CMS, any of those things like that, or just now over the last 9 months, we've had a lot of edits to the benefits for Kentucky in particular. And we update those in our office reference manual that's published on the portal. But in hearing the question, I don't know how we notify the providers of just the changes, like the red line, we'll call them red line edits. Do we create another document or a flag on the portal? I don't know. I don't know if we do that. I know we don't send a letter out indicating what has changed. It's sort of, we leave it to the providers to identify it in the updated ORM, but I understand that that's pretty inefficient from your perspective. Go ahead, Jean.
And Dr. Davis, one of the things that it kind of goes back to Dr. Munson, what you were saying, that there's been so many changes. We started a communication when there was changes that were occurring, and kind of stopped it because there was things that kept changing, like the next week, or it was a little bit different twist. And so we're trying to put together something that, and Dr. Davis, have to give him credit for it because he's done a great job of starting one. We just had to stop it because we wanted to be sure that all the changes that needed to be in that communication were kind of combined into one communication out to the providers. So we do have one started that Dr. Davis had done a while back, but we were just trying to kind of wait till some of the dust settles so that we'll make sure that we're not communicating something and then it changes. And DMS, I appreciate that there's definitely some clarity about the contacts and the dailies and all that other stuff. So I feel like there needs to be, from our standpoint, a communication that'll go out to you all that will kind of clarify some things. These meetings are very helpful because I think this could be added into those communications too. So I understand. I think we're all kind of there with this piece of it too. So, but.
Okay.
Yeah, I think I definitely understand what you're saying.
Okay.
Uh-huh.
All right.
Let me, if I may add, aside from this whole thing that we've been dealing with this year, trying to get everything squared away with the enhanced benefits or whatever, that's a little bit of a unique situation. But on these one-off edits, these minor things that are otherwise significant to your practices, after hearing the question, I'm going to look into how we can use our web portal to flag those. So you all have a little blinking light or something that says check for this update. And it's just a one sentence or whatever.
Mm-hmm.
Sometimes the full office reference manuals, those have to go through approvals from when we do them, we get them approved by Anthem first. So it takes a little time, but these other things, some of these things come at us pretty quickly. But at least those notices we can probably post on the portal, which I think we're going to look at that carefully now. Thank you for the suggestion, Dr. Munson. Because I can see it as a practitioner, I could see where I'd be frustrated enough saying, well, they didn't tell us that changed or whatever.
How was I supposed to know? Yeah.
Which, by the way, is going to apply to this next item.
Yep. So the last one then is Marsh. If you can address the Vision C schedule changes and revisions and how that's communicated to your member doctors.
Hello, this is Leanne Ellis again. So when there are any changes, we send the updates out in the form of newsletters, and those
Leanne, I think you froze a little bit.
Yep. We lost you for a minute there. So you send them out as newsletters and then paused.
When there are any changes, we send the updates out in the form of newsletters, and those are released every other month. But our portal homepage is also updated, and that's in real time. And in addition, as soon as we hear of any changes, we always do a provider fax communication as well.
Are the newsletters snail mail or email?
The newsletters, those are released by email.
Okay.
Yes, email.
Okay. And then in the chat box, Abesis was able to answer.
Hi, Dr. Munson. Yes, this
thank
is
you.
Added a comment. I did confirm that we fax blast updated vision plan sheets once they're finalized and approved by DMS. We will also update the provider manual and also post reference documents to the portal.
Okay. All right, excellent. So I think that wraps that up for everyone. Do any of our TAC members have any questions on this topic? Seeing none, we'll move on to the next one. So iQuest, this is kind of up that same alley. So how do we go about this question of a PA when it requires us to actually see the patient before we know how we're going to code? You don't know how you're going to code a patient until they're in your chair.
Right.
So can we get some guidance?
Sure. The short answer is, I'm going to give you the first phase of this is that happens all the time. It's going to happen all the time because, right, people present with whatever complex problem. A level 5 is indicated. You don't know that until they show up. You bill it. As what we do is we just require you to send in the claim with the chart notes, and then they're investigated. No different than we would do for a surgeon doing a cataract surgery, and they got an approval for 66984, but they didn't get an approval for 66982, and they just submit the surgical notes with their claim for the complex cataract procedure. It's kind of similar to that. And this is something we do, really in all of our markets, this PA for the level 5s. I don't think we have level 4 PA requirements though now, but without making this thing too convoluted, Anthem asked us to look into this when it came up on the agenda. And so sure enough, someone got back to me tomorrow morning from our company, and they said, and looked at, because I wanted to look at what our PA list is that's published, because the DMS approves our prior approval list that we submit to them, and then they say, okay, great or not. Well, I assumed that we were still had level 5 PA requirements, which I was wrong about, as it turns out, because when we submitted our most recent list was 2019, and we discontinued PAs for a whole bunch of procedures. including the 99215. And in fact, the 99214, I think it was after 4 per year or something, you had to have a PA or something like that. We discontinued them all across the board there, but which I hadn't recalled that happening, but that was all in there and that's what's posted. But our configuration still maintained the level 5 PA requirement. It was never revised in the configuration level. So apparently there were all of 3 claims in the last 12 months that were denied because of that reason. So in fact, 2 things. One, those claims have already been processed to pay, the ones that haven't already been paid already. Number 2, there's a ticket in right now to remove that requirement from the configuration. So there'll be no longer any PA requirements for level 5s, whether it's a 99204 or 99205 or 15 or 99204 or 14.
So then those would be a change that our providers would be notified once that process is completed.
Right. Yeah.
Okay.
And along with that, also associated with that is that the state used to have frequency limits for some of those procedures. They've removed them on the fee schedule. So we took guidance from the new fee schedule, where they're excluded. It says no limitations or something like that in the fee schedule. So we're removing the frequency limitations as well, based on the current fee schedule that was revised this year.
Okay, great.
Okay.
That's great news.
Yeah.
Thank you.
Okay. Sorry for the long answer.
Okay. And then I'm sorry, I'm trying to do too many things at once. So are there any limits on any of the 99 codes from iQuest standpoint? Or are they all gone? Are there any like frequency limits?
There are not. No.
Okay. Okay.
Not on the E&M codes, pardon me. On the 92004, 14, those still have limits based on the fee schedule. I think it's 1 every calendar year now.
So that's I guess that's more of a DMS question, because you're taking your lead from them. So I'm gonna pivot a little bit to DMS then. So how, and I don't know how this goes about, but there are limits on level 3 or lower. So 99213 and lower, there are limits on that. How is that something that can be removed? Because the 99213 is a very basic code for us. That is something that's done very often. I'll use a very easy example, dry eye. There's somebody that has dry eye. That's a code that I'm going to use every time I see them, if not something higher. And that is hard to do when it is something that is limited. So can anyone on DMS's side speak to that?
So say that, go over it one more time. So
the 99 codes level 3 or lower, there still are frequency limitations on those. The ones that we were discussing before are level 4, level 5. So those are the higher codes, more expensive codes that are used far less frequently. Those frequency limits have been removed, but the lower codes that are used far more frequently still have frequency limits on them. It seems counterintuitive and then also very difficult, because those are codes that we're going to be using much more often. So I'm not advocating for anything to have frequency limitations, but it really does not make sense that the most commonly used codes are limited.
If you want to send us in just a list of some codes that you feel like, we should raise the limits or possibly remove limits. We're currently doing change review for 2024 fee schedule, and we'd be glad to include those in our review. Okay.
We can get that to you. And then this may not be a you DMS question, but is there somebody from DMS that can confirm that the provider type 77, which is optometrists, are able to order services and bill for services at community health workers?
So yes, that question came up. We looked into it. They were put in under physicians, but their provider type wasn't actually added in the system. It was supposed to have been. So we made a corrective change order, and so that it'll all be, billed right back to July 1st when we started CHW. reimbursement.
So that'll be retroactive for that?
Yep, absolutely.
Okay.
Yep.
All right, excellent. Great.
Madam Chairman, this is Steve Compton,
Yes.
I have a question.
Yes, sir. Yes,
Back
sir.
on the discussion about limiting level 4s.
Yes.
Do other provider types have limits? Say an endocrinologist, a diabetic sees them 3 times a year and it's level 4. They order all the lab tests. Are they limited? on what
Yeah,
they
so
can-
it depends on the actual code, but the majority of, I don't know about the majority, it just depends, but a lot of the codes do have limitations up to a certain point, and then after that point, they have to have prior authorizations.
So it's not just us, not
it's not,
just,
no, every provider type has limitations in their fee schedule.
I can live with that. Thank you.
Okay, well, we are on to our general discussion. So do any of our,
Yeah, Carolyn, I have a question for Justin, if I may. I'm a little thick-headed, so I need a little clarification further on the QMB. So are you telling us that anyone that is QMB will have glasses benefit?
Right. So and that's not really my specialty. It gets into that, I don't think there's anybody on here from eligibility, but to my understanding, it's that is correct. It's the SLMB that does not, but everybody that has QMB will have their glasses taken care of.
Okay, and so are you saying that we should, and again, I'm just asking here, are we supposed to bill the whole thing to Medicare first, and then after it's denied, bill the glasses to Medicaid?
Yeah, you can do that. Yeah, that's correct. And but those glasses will be on the that bypass list. So when you send that, it won't deny it.
Okay, so, but we shouldn't send the glasses straight to Medicaid, knowing that Medicare is not going to cover them.
Right. You still have to send it to Medicare first.
Medicare first. Okay, and so we've already been denied several QMB. So can we rebill those, resubmit those?
Yeah.
Okay.
Absolutely.
All right. And then, Caroline, I have one other question. Just, Caroline, real quick. Is there any chance that iQuest or Visas might consider updating their frame groups anytime soon? I know a couple of our offices, some of the frames are discontinued. It's been so long, and that may be our fault. We just may need to get with the rep and get some new stuff in. But I know it's been a long time since we've had any frame refresh and that, of course, that only applies to iQuest and Visas. Is there any hope of that anytime in the near future?
This is John Davis from iQuest. I certainly will look into it because I know that we do refresh these kits pretty regularly. I want to say every 3 years, but I'll check into the Kentucky specifically for sure, Dr. Upchurch, and get back to you guys. And I'll obviously we can communicate with you directly, but maybe I'll submit it to KOA as well. Let them know as well.
Right. Thank you, John.
Yeah, that's a good question. Because they need to be occasionally done, and I know they revised some of those flex frames. The baby frames. I know they had to do that because somebody quit making them. Miraflex quit doing it or something like that happened. I don't remember, but I'll find out for you for sure.
Okay.
Get back to you straight away.
All right.
And hi there, this is Kim Gray from Avisis again. And I do believe that our frame kit was just updated recently, like within the last couple years. But we would be happy to reach out to our lab vendor and discuss that with them and see if they have any plans for updating that kit here in the near future. We will get back to you on that.
Thank you.
okay, great.
Dr. Munson, I've got an iQuest question. And I
Go
hope
on, Dr. Compton.
I hope I can enunciate because I don't do the billing, so I may be a little bit lost. As I understand it, we have to get prior authorization for iQuest for children. This is for children for a replacement pair. And then when we do that, we've had a handful lately that it says they've exhausted their benefits. We've only billed them once. Now, I guess they could get it somewhere else, but I don't think they all have. And then we had a patient call their, I guess, called iQuest, and they told them we'd billed something twice, and we certainly haven't done that. I don't know if there's a glitch in the portal.
That's what I'm thinking.
I mean, I kind of hate to go through the PA process for children anyway, but school's about to start and these kids need to see.
Yeah, I definitely, well, I'm going to be reaching out to Classic either way for this other issue. So I'm going to reach out to them today, in fact, because that doesn't make sense to me. Unless there's some kind of glitch like you were suggesting, maybe. But if there's a way to get a few sample claims, it would be really potentially helpful, even if just 2 or 3.
We can do that. Just send them to you.
Yeah. I think your staff has my email address. At least I can direct them to a claims specialist who knows what's going on, who deals with Kentucky every day, who deals with the portal, the eyewear ordering every day, you know. So I think I can find one of my experts, please.
Can you put your email in the chat?
Sure. I'll try to figure that. I'll try to figure out how to do that.
Say, or you can just say it right now. We'll write it down.
Yeah, it's okay. Ready? Is she listening? John.davis@dentaquest.com.
Davis.
John.davis at DentaQuest. Yeah, DentaQuest.com. Yeah. Thank you.
Got it.
Yeah, I won't forget about you. I'm going to find it. I'm going to look into it this afternoon while I'm at it. Just start looking at it in general and see what that seems weird though.
Okay.
For sure.
Thank you.
Yeah, I'm glad you brought it up, Dr. Compton. Thank you.
Thanks.
Yeah, those are annoying.
All right, so do any other of our TAC members have anything else to add under general discussion? All right, seeing nothing, do any of our TAC members have any recommendations for Dr. Compton to take from our TAC to the MAC meeting, which is September 28th? All right, seeing none, our next meeting will be November the 2nd at 1 p.m. So mark your calendars, and hopefully I will be back as a participant and not as a leader, as Dr. Burchett should regain his status as the TAC chair. So I appreciate y'all being here today. So that's everything I have. So y'all have a great rest of the day. Thanks so much. Bye now.
Thank you, everybody.
Thank you.
Thank you.